concept. So, your research identified that there were 13 treatments that had demonstrated the evidence of efficacy as strong as or stronger than some medications that have been approved today. So, what do you feel was the most surprising treatment that showed signs of efficacy that was abandoned?
So one of the most surprising was choline phosphorate. And the thing that was surprising about that was the size of the effect in the studies. When we looked at all of the outcomes together, all of the evidence for it just had a massive treatment effect, and has been abandoned for a couple reasons. One being that it's not as lucrative for pharmaceutical companies to pursue this particular treatment because they wouldn't be able to have a large margin on it. But another one that was surprising are things like ginkgo, and the boswellic acids, because they are supplements, and that people have given up on them. But if again, as we look at all of the evidence together, that those treatment effect sizes are actually big enough that they should not be dismissed.
So, what modifications to the trial design do you feel like could have resulted in a different determination for those specific treatments?
Yeah, so these ones actually are also more along the lines of symptomatic treatments, and so you'd think that just following the same paradigm would have led to a similar result. But ultimately, when we're looking at Alzheimer's disease and other complex neurodegenerative diseases or complex diseases in general, we have to understand that the outcomes that we are measuring might be too narrow. They may be measuring only a specific aspect of it, and that can be very successful, or it can be less successful because we are measuring just a slightly wrong part of the disease with that outcome. And so I tend to think of these sometimes as like investment portfolios for any savvy investor out there. One knows that the safest route is to diversify your portfolio, and in this case, that doesn't mean doing co-primary endpoints. What it means is taking all of those different outcomes and putting them together into one outcome. The best way to do that, if we have narrowed in on a specific segment of the disease, severity of the disease, the best way to do that is through a composite score that has been specifically designed to align with disease progression, so that when we actually modify the disease, or when we are altering even through symptomatic disease, the specific areas that are covered by a composite, we have the best chance of seeing an effect. So that would be one thing that I would definitely encourage people to do differently, is to try and bring all of those outcomes into a single outcome, instead of assuming that just because you're modifying the disease, you are equally likely you have the same probability of hitting on one outcome as you do on more than one outcome. So that would be the biggest change that I would encourage people to do. There's lots of small things though. That's one of the reasons why we exist, because the disease is so hard. Allowing additional variability is not an option. And so even just designing your study from the get-go to have your database align with your CRF, which aligns with your data sets, the data set formats that you're using, which aligns with your table listing figures. If you can get all of those things to be in sync, you're gonna keep all of your data as clean as possible. So that's one thing. Another thing that we would recommend is making sure that your analysis lines up with your treatment effect, with the known issues. So little things like making sure you're including proper covariates, or handling post baseline initiation of acetylcholinesterase inhibitors. Just lots of little things like that. All of those things add up to a big failure if you aren't taking care of them.
What about, Sam, like gender differences? Is there value in creating a large enough subpopulation cohorts of male and female to tease and identify those differences, or do you feel like it's not necessary?
So I don't know that it's as necessary to focus on that. You know, it becomes, the smaller your sample size, the bigger
Right.
that is going to be an issue. Um, but by the time you get to a phase 3 trial, usually you're in Alzheimer's disease, the sample sizes are just by necessity big enough that the gender differences aren't going to be as important. Historically, the gender split has favored females, but as we move earlier in disease, it's going to shift towards males. Although what's interesting about that is even as it shifts towards males, it hasn't so far ended up favoring males.